All right, guys, we're back in Santa Monica for a new episode of Ask the Doc. We just had some great food with
Yes, we
Dr.
did.
Ren as usual, and we have a special guest today. You want to show the guest?
Yes, please.
Ta-da! The very famous Jenny Worth is with us today, Olympia athlete. She may have some questions, right?
I hope so.
Yeah.
You need to talk. Okay.
Some hard ones.
All right, Doc. So we're gonna get started with question number one.
First one says, "Hey Doc, thanks for taking my question. Love the show. Thank you. I have issues with high blood pressure, and my family doc wants me to take meds for it. I'm not sure if I want to do that yet. Is there any over-the-counter supplement you know of that could help me reduce it? Also, how would being on TRT or steroids affect that? Thanks a lot, Dr. Rand. Appreciate all your help with all of us. Brandon P." So that's actually a good question. The first thing, though, is, as we always say, don't take my advice over the advice of your physician who's actually treating you, that knows your individual assays and your vital signs and all that good stuff. So if he or she is recommending hypertensive medication, give it very, very strong consideration. In the meantime, though, the answer to your question is, with regard to supplements that may help lower it, the mechanisms, I'm probably better off discussing than actually listing supplements. I'll list some, but nitric oxide is going to expand the vessels, so to speak. People know of nitric oxide mainly for its use in, you're blocking the reabsorption, as it were, of nitric oxide when you use the PD5 inhibitors we talk about, like Cialis and Viagra and Levitra and then Stendra, brand names for all of the ones that are used for erectile dysfunction, which, that's the category. Like so many other supplements and drugs, don't get caught up in the category, because again, raising your nitric oxide levels can be very, very beneficial for a lot of different reasons, not just erectile dysfunction, especially for the ladies who have no issue with erectile dysfunction for obvious reasons. But, and again, this is why it's misleading, but actually those PD5 inhibitors, they're called, were originally designed for pulmonary hypertension. So the idea is that you're going to relax the smooth muscle of the vessels so that you've got a larger area. It's all about physics for that same amount, the same volume of blood, which is going to reduce your blood pressure, right? So anything that does that could conceivably help lower your blood pressure. Now, I just mentioned drugs that are not obviously over the counter, but there are other things out there that will raise nitric oxide levels, like particularly in the younger of us. I say us, not me, but younger individuals, where you have two mechanisms by which we make nitric oxide, but the mechanism which uses amino acids like L-arginine, L-citrulline, will be enhanced through the process of stoichiometry. You have more of that substrate, or particularly if you're missing any, then you can make more of the the nitric oxide when necessary. So those are a couple. You can also get other dietary sources, which really involves a different mechanism of nitrate and nitrite, like beets and beetroot juice is pretty famous. I always have to give, because it's due him, Dr. Nathan Bryan, a plug for some of his products. You can find them at no2u.com. Things that actually work, just aren't loaded with sugar and have a flavor of beet. So let's see if there's anything else. There are other things out there. If you typed in Google, ways to naturally, as it were, or supplemental sources of raising nitric oxide, they're out there. Again, different mechanisms for the same purpose. Also, I talked about smooth muscle. Magnesium has been controversial as a source of lowering blood pressure, I think, because, there's different types of blood pressure. There's secondary or essential. Essential basically means we don't know why. I'm being facetious a bit, but and then there's secondary. For example, if we call it renal artery stenosis, for example, where the artery to the kidney gets constricted. You might have plaque in there or some other reason, and so essentially you're getting the kidney's picking up on a false signal of blood pressure, and so acting in a way that, because it's not getting enough flow, they're saying, okay, well, we need more retention of fluid, so it raises your blood pressure. But magnesium would work on someone who tends to be type A and who might have greater tone, we might call it, in the smooth muscle of those vessels, because they're just wound up all the time. Their sympathetic nervous system drive. And so, obviously in one situation, renal artery stenosis, magnesium's not going to do anything, really. But if someone's a little wound up, because it relaxes you, okay, that's one of the reasons we know you get more blood flow to the area, is that smooth muscle in the vasculature gets relaxed and you get more flow. This is something that could lower blood pressure. Are we talking about with these substances, major numbers, 20 points? No, but I've seen studies, 3, 4, 6 points of diastolic or more likely systolic, but it doesn't matter. Anything's better than nothing. So we, and there's others out there. I mean, just having proper levels of electrolytes that help control the fluid within the vessels as well as in the cells can make a big difference. Supplementing with potassium, not too much, and definitely orally, right? For those junior scientists, doctors, hackers, they call them out there. Don't be doing potassium intravenously. You can kill yourself very easily. But you can take oral supplements fairly safely. A banana, I think, has 450 milligrams of potassium. They have supplemental potassium capsules that might be 60 milligrams each. So, you can safely take those with food. And the idea is that it's going to push sodium out of the system. Calcium has to be regulated properly. So keeping track of your electrolyte balance is important. Garlic is one that's been shown to, in some studies, to lower blood pressure. Coenzyme Q10. There are others out there. Just do a little research. I'm sorry, I don't remember all of them off the top of my head. But again, if your blood pressure is significantly elevated, you want to get on a blood pressure medication. Don't be biohacking or whatever you want to call it with some of these things. If you're in that situation, and certainly maybe a lot of these, always run it by your doctor, can be used in conjunction, so maybe you limit some of the amount of medication you're taking. But the other part of the question is also, how would being on TRT or steroids affect that? Well, that's two separate questions, really. Testosterone is a steroid, but it's not what I'm assuming Brandon's talking about, an anabolic steroid, and they have different effects. All anabolic steroids, all of them, will jigger your lipids a bit. So you might see a rise in LDL and a depression in HDL. And over the long haul, if atherosclerotic plaque is built up, then that could affect your blood pressure for obvious reasons. You're hardening their arteries. You're blocking, in some cases, the flow, right, depending upon where you are and which vessels and whatnot, significantly or not. And that can effectuate hypertension, affect your blood pressure for sure. But also, and we we alluded to this with magnesium, for example, I've seen in patients that go on testosterone that are a little high strung, and given the energy to be more so, you can see an uptick in blood pressure. Again, with anabolic steroids, it doesn't happen all the time, but that's a significant source of risk, I guess, in blood pressure going higher. Now, you might go from 115 over 65 to 120 over 70. Well, okay, that's not hypertension, but that's a rise, and I think that's the question here, right? So it may not cause hypertension, but it would be expected. And if it doesn't cause plaque, which it won't cause it, it would facilitate it, and that's a whole other topic. But then anabolic steroids, the rise would be temporary, right? And ditto for testosterone, because you could be on or off it. But the idea behind testosterone raising blood pressure would be, again, energizing that individual, activating the sympathetic nervous system in someone who's already kind of wound up to begin with. And you go off TRT, lower the dose, or compensate for it, meditation, stress reduction, and it goes back down. So it's less of a physiological direct mechanism. Like, for example, I would argue potassium might be, because you're lowering sodium by taking the potassium. It's a different mechanism, but yeah, they could affect your blood pressure. So just, be aware, take it in consideration, and just briefly, not to get too far afield, but take your blood pressure at home. Most physicians now believe in that, so to speak. Will recommend that because of what we call white coat syndrome. Taking your blood pressure in front of somebody else. If you take it at home, you're more likely to see what your blood pressure really is, rather than, oh my gosh, I'm going to see, and this is typical. That's why I mentioned it. It's not something that should be typical, but you're going to a physician that didn't prescribe the TRT. And so you're nervous about, is this going to make my blood pressure higher and I'm going to have to fess up or whatever? My point being, you should be communicating with all your physicians about what you're doing. And if they're not on the same page, then you should do something about that. Because everyone should be on board with what you're doing. Not necessarily on board, but everyone should know. And if you got one that says, okay, well, I object, okay, well, then know that. Don't wait till last minute to find out about it or have a problem. But I know I'm going far afield here, but to invest $100, $150, and the difference in price is, the bells and whistles. To get a good cuff, usually Omron, and I don't get a free toaster for recommending them or anything, but you can get one of those at like a CVS or something, and get an accurate reading, arm, not wrist, and find out, how these medications may or may not be affecting and supplements your blood pressure.
Awesome. Thanks, Doc.
Yeah. So the next one starts, hello, good afternoon, doctor. How do they know it's afternoon? Do we always see in the afternoon?
Good question.
I want to start by saying I've watched all your YouTube videos. Well, thank you. I've been following you for a number of years and really enjoy the work you do. Well, thank you. I have a quick question. I'm thinking about starting a triple stack of Sermorelin, Ipomorelin, and CJC 1295. I've already ordered it from a reputable company. I just don't know where to begin. What should I start myself with? How often should I take it, and so on? Sonny. Well, that's a great question. With these growth hormone secretagogues, meaning that's just a fancy way of saying they're all going to initiate the production of growth hormone from within your pituitary gland, which I argue is a much safer way of doing it. Safe or not, let's not even go with safety. It's just kind of a smart way to do it if your objective is to get a level of growth hormone that you were, say, producing when you were in your 20s, right? With an IGF-1 of, say, 300, maybe 350. Again, commensurate with that age period, you can do that, and that would be roughly the equivalent of, say, 3 to 4 IUs of exogenous growth hormone. You can do that certainly way more cheaply, legally, and the fancy word is you're recrudescing the gland. You're telling the gland to sort of go back in time in terms of function. You're getting it to step up to the plate again and produce like it did in your youth. And so one of the advantages of that is, of course, your recrudescent gland. But if for some reason you miss your dose, you miss a lot of doses, you're not going to be without. Whereas if you use exogenous growth hormone, you're suppressing your own production for a long enough period that if you miss a dose, your pituitary is going, oh, but you need me to do something now all of a sudden? Well, we're not ready, right? So in addition to that, over a longer period of time, and Dr. Richard Walker showed this in his studies using Sermorelin, which used to be Jaref, the brand. So it was really one of the original GHs ever, if not one of the. But after a while, I think it's a year and a half, you can then back off on your dose because the gland has recrudesced and you don't need as much to do the same work. And this stuff gets expensive. Especially when you're comparing growth hormone, exogenous growth hormone, to these GH secretagogues. And that goes to something else. And you say a reputable company, I have to say this, just, everyone's been there, done that, I guess. But if you can get this from a pharmacy, a compounder, you're better off. Test Sermorelin, which wasn't mentioned here, is the new trademarked version of a slightly different molecule than Sermorelin. And that one is available, at a CVS, right? Not even a compounder. I say that, I don't mean to step on the toes, because I'm a registered libertarian, but I also have to wear the responsibility cap of a doctor. There are companies out there that have been providing these substances, before the FDA approved it and then said, oh, they might be unsafe and sort of disapproved it for a long time, that are, considered reputable companies. Mm-hmm. So I don't mean to poo-poo those companies at all. They provided a service, whether it's been considered on the, I don't know, whatever scale you want to talk about in terms of being, if it were illegal, I would imagine it would have been stopped by now, but, better or worse, whatever. So the question I would have, though, is why we would need a triple stack, as it's put here.
They all do the same thing.
In the end, yes, you're getting a production of endogenous growth hormone, right? But you've got different mechanisms by which they work, where, you might have really two mechanisms. One that uses the ghrelin pathway, and the other that uses an analog, or a fraction, like with Sermorelin, it's the first 29 amino acids in that peptide that is growth hormone releasing hormone. So you don't need the extras, apparently, according to the body. That'll work. It's like one of those skeleton keys. And so you can get away with using that. It acts as a growth hormone receptor. Growth hormone, what am I trying to say? Growth hormone releasing hormone, sorry. Excuse me. And then again, you have this other that works through the ghrelin pathway, which has a side effect of hunger, but that's why we take it at night. And you've got different peptides, but you also got one he didn't mention here. I'm assuming Sunny might be a girl, I guess, but Ipomorelin, which also is known as MK677 on the boards. That one's orally administered, and I think we talked about it before, but that works through the ghrelin mechanism. So you want to take it at night so that you can take it right before bed and go to sleep. And actually in all these, because we're using the endogenous system, you want to take them at bedtime, not I'm going to channel surf and fall asleep watching TV, because whether they engender a sense of hunger or not, you want to get the best out of them, and your body produces more of its own growth hormone, encouraged to or not by these substances, at night, particularly when you drop into deep sleep. And you don't want to have that in any way interfered with by elevated blood sugar, which will raise insulin levels, which will compete directly, and I'm being nice when I say compete, because it's not even a competition. It will significantly reduce your production of growth hormone. So right at bedtime, you've given yourself 2 to preferably 3 hours between your last meal and bedtime. And I always joke, it shouldn't be a Jethro bowl of something because you think, oh my God, I got to make it another 3 hours. Eat a regular dish of whatever you're having, and you should get the most out of it that way. But the triple stack, if you're going to stack up anything, I think the consideration would be, and this is just a theoretical one, I haven't seen any studies which bear it out. As a matter of fact, in my practice, I've seen CJC 1295 combined with Ipomorelin, and those work by 2 different mechanisms of action. They don't do as well as Ipomorelin, which works through just the one, at whatever dose I found. So, but theoretically, if you come at it from 2 different angles, right, the ghrelin and the growth hormone releasing hormone, you might get a better result, but that's just theory. So anyway, the question would be, why would you need to go to a triple? Certainly a double would make even more sense than a double, if at all. So I think that answers. Oh, how often should I take it? I would take it every night. I don't know. There's been a legend created amongst bodybuilders to take something that either replaces your own production of growth hormone or that engenders it 5 nights on and 2 nights off. I don't know the rationale behind that. Does anybody here? I always thought, well, maybe it's because it's so expensive when they're using real growth hormone back in the day, and it's a good excuse to save a little money for 2 days. The other practical part of that is it may be because with growth hormone you can see some accumulation of water, and you might give yourself a couple days to shed that excess water weight. You might also shed some excess leftover food, we'll call it, because growth hormone use tends to slow the motility of the bowel, which I think we just mentioned two areas that might contribute to what people refer to as GH belly, that bloat that some people who take too much, way too much or just too much. And I'm saying this because it's used in the bodybuilding community, right? At a dose that would be much higher than a replacement dose to get you to something you had when you were, say, 20 years old. So anyway, I would take it every night when used in the dosages that are recommended to stay within physiological norms, as it were, optimized.
Awesome. All right.
This one says, Dr. Rand and Dave, thank you for the great show you two produce for the rest of us. We're getting some compliments. This is good.
Well, yeah. Do you like it?
Yeah.
What did you expect?
Well, I just normally I jump right in, but it's nice to hear. Not the compliment, but saying that it's providing some useful information. Yeah. What steroids are the best to increase the appetite? I know it is toxic for the liver, but I heard Anadrol was used to combat anemia. Any others? Thanks, John B. For appetite, that's going to be really individualized and probably pretty insignificant. It is touted that nandrolone, what used to be manufactured as decadrolin, will help increase appetite, and I've seen some of that. Anadrol, is it increasing appetite directly, and same for nandrolone, or is it because you're amassing new muscle, right, which requires more calories to keep it going? I mean, the reason why we have to eat so much food is to keep muscle mass on our frame. Mm-hmm. And if you use it functionally, meaning you don't just sit there on the couch and flog a mirror, you're going to need even more calories the more muscle you have. The brain can survive on about 300 calories a day, whether you study Einstein or watch the boob tube and stupid shows. Anything that's anabolic that is used effectively to put on muscle mass should increase your appetite. So I wouldn't get too far into, okay, which is the better of these. Now, that said, there are those which, in the bodybuilding community they've known for a long time are better for reducing your appetite to some degree, and they're the ones that tend to ramp you up, I would say, right? And they're close cousins, two of which are legal in the United States. Oxandrolone, which used to be manufactured as Anavar, and stanozolol, which is actually still manufactured as Winstrol. Those are DHT derivatives. They tend to ramp you up. They also work not only to accrete muscle mass, but they're catabolic in nature toward fat. And maybe with the second effect, you can limit some of your intake because you're releasing some of your internal stores of energy, right? But it might be because, like with coffee to a degree, at least for 20, 30 minutes, you have some coffee, the sympathetic nervous system is kicked in and you're not hungry, right? I think there's a little bit of that going on. And I haven't read any studies that talk about this appetite and anabolic steroids specifically, but that's just what I've noticed over the years. Again, just observe what I think is observing in practice. And then there's the third cousin that's a DHT derivative called Primobolan, which is not available in the United States, unfortunately, because it's an injectable cousin, a version of this DHT derivative, which is very effective, very anabolic. But again, in terms of increasing appetite, those would not be my first choices. Anadrol, when you're talking about being toxic for the liver, that brings up a whole other concept here that I will unapologetically dive into, which is physicians and others will look into an elevation in ALT and AST, considered liver enzymes that result when someone is taking an anabolic steroid, whether it be oral or not. Okay, particularly it depends on where the extra carbon is. We shouldn't get too technical about it, but there are different versions that have more of an effect purportedly on the liver or not. But what's overlooked is that, yes, liver can release ALT and AST when it does its job. When the cells lyse, that's released in the bloodstream and you see an elevation, but so can muscle tissue turnover, right? Which is going to be greater in somebody who's properly using anabolics to accrete muscle mass, right? Mm-hmm. So one of the things I draw is blood for an assay of the GGT, which is specific to organ tissue. so that you can determine the difference. Because you'll see someone with a GGT assay, which again is specific to organ tissue, liver being one of those organs, along with the pancreas and others. But if you see someone with a GGT of 12 and an ALT, sometimes an AST, it can be either, but what I've seen is typically ALT is elevated more so than AST when it comes to muscle mass. But again, it can be both, and sometimes AST more than ALT. But when you see an elevation of, say, to 65 or even 80 sometimes, it's not because of a fatty liver or for liver damage secondary to the anabolic steroid itself. It's because you got more muscle mass, which, duh. Again, if you're using these to accrete muscle mass, they're doing their job, and the elevation is not because of toxicity to the liver, which again comes back to the liver just doing its job, if that's what it needed to do. But that's not the case here, is my point. It can happen, and I go off on other tangents when it comes to anadrol, but not my favorite. And yes, it is listed in the PDRs, which don't really make a whole bunch of difference anyway, but in the literature, it's listed as an anabolic steroid that's used primarily for anemia. I would not recommend anadrol for just about anybody unless they were really having trouble with cachexia, difficulty putting on weight. You can use really any anabolic steroid, if appropriate, for the treatment of anemia. You can use testosterone for the treatment of anemia. So it's not specific to anadrol, even though that's one that's listed. Just like for stanozolol, Winstrol, it's also indicated for angioedema. And actually, that one does apply better. I mean, everyone knows who's steeped in this world of anabolics, and whether it's as bodybuilders who find out on that side of the table, or those that prescribe it because of wasting disorders or whatever. Winstrol actually will get rid of angioedema. It's used for getting rid of that third space water for sure. But in the case of anemia, I wouldn't think of anadrol as particularly that much better, and certainly not worth some of the nasty side effects like water retention, irritability that can occur even with what would be considered light doses of anadrol. So let's see if I got all the questions. Toxic, no. Any others? I mentioned that. So yeah. Oh, so and as far as appetite goes, there's a bunch of things that can. Didn't we talk about this last time about ways to increase appetite? Cannabis derivatives and maribinol, I think is what the brand name is. Did we go through a list of that? Anyway, you don't necessarily need an anabolic steroid to increase appetite, is what I'm saying. And when we're talking about steroids, again, that's probably not what John B. asked, but that includes corticosteroids. And for some, that can increase your appetite. For some, it can destroy it. It's going to release sugars, corticosteroids do, and for some, afterwards, it makes them more, it's kind of counterintuitive. It can make them more hungry. Certainly can make you hold water too, but that's beside the point. But it can also just hammer your appetite. But I guess what I'm trying to say is there are other things besides steroids that can be used, obviously, to increase your appetite. And we just mentioned one earlier with Ipomorelin. I've used that in very small doses relative to what you would take at night to engender growth hormone release, like just 10 milligrams, half hour before each meal, if you wanted to. Remember the GHRPs?
Yeah.
When they were available, GHRP2 more than 6, I believe, both working through the ghrelin mechanism, would fire people's appetite up big time. So if someone were, really trying to put on weight, they're, cachexic is a fancy word for saying, underweight or whatever, man, half hour before a meal, forget about growth hormone release. They will scarf down whatever's put on their plate. Yeah. Right. No, that was taken off in May of I want to say way back in 2015.
All the good stuff.
Anyway, hope that helps.
All right, thanks, Doc.